encourage you throughout my presentation. I always start with a disclaimer, and my disclaimer is here. This is a class that is a judgment-free, safe place where your voice matters and your experiences matter. If we don't get through my entire presentation, you can read it for yourself on your own. If we have a lively discussion with interaction and sharing, I think that's more valuable and important, in my opinion, than me standing up here and talking and sharing my experience, because I think we learn best from one another. So if you are comfortable, you have questions, please unmute, share your video if you would like. If you have questions, if you have concerns, if you have a story to share, please do so. I encourage that. And like I say here, hopefully everyone feels comfortable sharing. It's our responsibility as attendees to also make it a comfortable and safe place for others. So what I'm going to talk to you today about is diversity in research and recruitment. I am often approached by researchers and study teams after the fact when their enrollment is dragging and they don't feel like they're getting an adequate representation from the diverse community that we serve, and they are reaching out for assistance and support. So what we'll talk about today is the class standards. Just by a show of an emoji or something here on your video, who is familiar with the national class standards? Is anyone on this call familiar with the class standards? Okay, we will go over the class standards and how to best apply that to our research activities. We will go over identifying what health inequity looks like and how this impacts research. Identify some common barriers to diverse participation and enrollment into research studies, and understand how health literacy impacts not only health outcomes, but also recruitment efforts in research. And then I want you to just know that you're always welcome to contact me or my team. We have a plethora of resources available, both to undergraduate, graduates, researchers, individuals who are interested in conducting research. We try to look at things from a participant standpoint and how this will look for the community in which you're trying to study. So we are actively involved with helping researchers when they're designing their studies and their recruitment strategies. We are here to help and to help hopefully enable you to meet your enrollment goals, but also to be respectful and helping to build trust within our communities that have been marginalized and mistreated through decades of poorly conducted and unethical research. The class standards are the national standards for culturally and linguistically appropriate services in health and healthcare. And this is the definition from the Department of Health and Human Services Office of Minority Health. The underlying principle that I want you to take home with you from this is the principal standard is to provide effective, equitable, understandable, and respectful quality care and services. Research is a service that we provide as an academic institution. So I feel that the research that we conduct across campus is a service that we provide. And to do that in a responsive, that is responsive to diverse cultural health beliefs, practices, preferred languages, health literacy, and other communication needs. So responsive means reacting quickly and positively. I have interacted with study teams that have reacted, but not in a quick manner or in necessarily a positive manner. I have had stories, if someone has a concern or a complaint that they don't feel like they can take to the study team, they're often contacting my office to share with me something that either went wrong, that they have questions about, or want to complain, not complain, but raise concerns and feel like they have been treated unfairly, unethically, and misunderstood or misinterpreted the consent process. So we are really here to help serve that bridge between researchers and study teams and our community to help foster a respective and culturally appropriate interaction. So as we think about the principal standards to provide effective, equitable, understandable, and respectful services, Some of the things we talk about are how effective is our recruitment efforts? So are we actually reaching the community in which we're trying to do our research with? Oftentimes researchers will not be immersed in the community that they're hoping to study. And there tends to be a little bit of a lag between individuals willing to take part in their study because they did not feel like they were included in the design of the study. And being included in the design of the study is paramount to providing participant and patient-centric research studies. So let's go back to the class standards. So cultural and linguistic competence, according to the AHRQ, linguistic competence is providing readily available, culturally appropriate oral and written language services to limited English proficient members through the means of bilingual, bicultural staff, trained medical interpreters, and qualified translators. I highlight and bold that to hopefully draw your attention to the fact that not everyone can serve as an interpreter. We have had situations where family members unfortunately have served as an interpreter for a study participant. I can share one quick story with you. In the beginning, I've been in this position for 14 years. I've been involved in clinical research or research in general for the last 25 years. I've seen a lot of different things. The one story that really made me very passionate about what I do and the need for quality trained interpreters and translators was a situation where we had a mother and her daughter. The mother had a kidney transplant and was in a research study and was receiving an investigational drug. The daughter had just turned 18 and was serving as the interpreter for her mother when they consented into the study and for study follow-ups. Unfortunately, after the surgery, I was rounding on participants on our clinical trials floor at the hospital. And one of the nurses came up to me and said, "Oh, you don't need to go in there because the participant doesn't speak English." And I said, "Well, that's all the more reason that I need to go in there and introduce myself and let them know that I'm here to serve them as well." So I unfortunately do not speak any other language other than English, but I am very resourceful and established our research translation interpretation office solely for this purpose. So I reached out to one of my team members and had them come up to join me to go introduce myself and talk with this participant and her daughter. When I went in, we had a nice conversation through the use of the interpreter and spoke with the daughter and the mother. And long story short, we found out that the daughter, after the participant's kidney transplant, misunderstood the directions on dosing for the study drug and was quadruple dosing her on an investigational drug because she was supposed to have the drug 4 times a day. Unfortunately, she was giving her 4 times a day. So she was getting 16 pills every day since her kidney transplant. And if you know anything about study drugs and clinical trials, someone mentioned to me, well, they would have caught that eventually because they would have run out of study drug. And when they did study drug rectifying the count. But when you have someone that has just gone through a transplant and is now experiencing a medication error, every pill matters, especially when it's an investigational drug. We ended up having myself, my interpreter, the daughter, the mother, the pharmacist, a second pharmacist, the PI, a sub PI, and 2 nurses in the room by the end of this conversation to get this figured out and resolved. And luckily the participant had no major side effects from being quadruple dosed for a couple days, excuse me, post her kidney transplant. So linguistic competence as an institution is invaluable. We need to ensure that we have trained medical interpreters and qualified translators serving our community members at large. Cultural competence, this is where we get to the impact of our researchers and study team members, ourselves. the institution, a set of congruent behaviors, attitudes, and policies that come together in a system or agency or among professionals that enables effective interactions in a cross-cultural framework. Our policies are being reestablished now and revamped. Hopefully, I would like to see in the next couple of years that we no longer allow discrimination based on national origin, which is a violation of Title VI. When we exclude people from taking part in a research study that doesn't speak English. In my opinion, as an institution, that is where we need to step up and align our policies with some of the federal regulations that are out there and realize the impact this has both on our research, the diversity in our research, and the generalizability of our research studies. So cultural and linguistic competence, the ability of healthcare providers and healthcare organizations to understand and respond effectively to the cultural and linguistic needs brought by the patient to the healthcare encounter. So how does culture impact a person's health? Why does this matter in research? Well, Dr. Wanda Jones, the previous director of the Office on Women's Health, said culture defines how healthcare information is received and how patients make choices about their treatment. By understanding, valuing, and incorporating culturally and linguistically appropriate standards when designing and recruiting minority patients into new clinical trials, healthcare practitioners and organizations can support a healthcare system that is truly inclusive and serves the needs of the most vulnerable. So, what are the aspects of cultural identity? So here's just a few. So sex, race, age, education, socioeconomic status, geography, someone who lives in a rural community versus someone who lives in an urban setting, sexual orientation, spirituality, health beliefs, practices, environment, military service, ethnicity, abilities. All of these things and many more impact someone's cultural identity. So how do we apply cultural and linguistic standards to such a diverse community in which we serve? Well, we know the need for increasing diversity in research. We know that most research studies enroll close to 75 to 80% white male participants, and that there is a huge underrepresentation of minorities and marginalized communities within our research studies. I pulled this cartoon and I still need to pay for it. I understand that I need to do that. Didn't have that opportunity, but I like this cartoon. I've written an innovative, multi-platform, blue sky, interdisciplinary, paradigm stretching insight into the abuse of jargon. Great idea, let's study it. Oftentimes when I see a research study come through and they're asking for help with recruitment, as I think recruitment is is the most important aspect of accomplishing and meeting the aims of our studies. Unfortunately, the study design didn't have the patient or target population central to the design of the study. And that is incredibly important, especially when we're trying to build respect and trust with community members where we have done horrific things to. It's important that we start at the table as far as designing the studies. We are oftentimes the studies that we develop and implement are our ideas, the researchers' ideas, and don't necessarily meet the needs of the community. By having the community members centric, patient centric at the design of the study, we're able to meet the needs of the community and provide the aims and the targets of the outcome of the research to meet their needs, and to in turn that will help enrollment and recruitment activities and efforts. So what language do we use and actions that are typical or standard in study communications that are contributing to the inequities in research? If anyone in here has read a consent form, the average reading level of an informed consent is typically at the 10th grade reading level or higher. So the language that we're using to describe our studies, the flyers that we're using, the informed consents are written at such a level that a peer would understand what we're asking them to do, but an average person would most likely not glean from that information what actually is being done in that study. So by applying class standards to our clinical trial designs and recruitment efforts, we can increase generalizability and reproducibility of research results. We want to make sure that the research is adequately representing the community in which the research is being conducted. In Salt Lake alone, we have 129 different languages spoken in the Salt Lake Valley. That is huge. It is not what we currently are not meeting the needs of all of our community members. So how do we approach this? We all come in with biases, and that impacts our research recruitment efforts. So how do we look at those? How do we address our own biases and those of the study team and the PIs that we're working with? So one thing I think that we need to first acknowledge is that we have them. Once we can identify them, then we can work to address them and change them. We can actively address healthcare disparities through our work in research. Research is the starting point for healthcare disparities and health inequities. So health equity starts with research equity through access and opportunity. So what are your blind spots? Do you have blind spots? Is there something that you're not acknowledging that's keeping you from meeting your recruitment needs? I have another story. I was working with a researcher who was doing HIV studies and had a study that was recruiting newly diagnosed or young men between the ages, I think, of 18 and 35 that had just been recently diagnosed as HIV positive. When I asked him about his recruitment strategy and what he was doing and where he was recruiting from, he said from his clinic. That right there is one limiting factor. If you don't have insurance, if you don't have access to healthcare, if your insurance accepted at the University of Utah, you're going to meet a lot of barriers to accessing this research. So I did my work and I came back to him with a great opportunity for him to post his study. I contacted Grindr, and Grindr said this would be amazing. We need this kind of advertising. We need this type of research for our individuals that are using the app. When I mentioned this to the PI, he was unfortunately not willing to put his study on Grindr and opted not to do that. When I met with the study coordinator and asked her what her current flyer looked like, she had started to redesign the flyer with a little stick figure of a person with a megaphone, and out of the megaphone was positive exclamation part, reach out for our study. And I was a little bit, I use it in my presentations because I think it's very apparent that they were not working within the community to understand the needs of this most marginalized community. I don't think that anyone that's looking to take part in a study is going, especially if they were just newly diagnosed with HIV, would be attracted to a study that obviously is missing the mark on what the implications of a diagnosis like that would be to a young individual. So we have to be willing to look at our biases. We have to be willing to understand where and meet our participants and our patients where they are and not bring them and insist that they come to where we are. Our informed consents need to be written in lay-friendly terminology that an average person is able to make an informed decision on. So tips for effective cross-cultural communications. First off, acknowledge your differences. Build self-awareness. We all have biases. Do you know yours? Start talking to your friends and family and colleagues. I think we oftentimes don't want to acknowledge that we have them and that we have blind spots that we're not seeing. I can share with you a personal story. I love to go thrifting. I have a favorite little thrift store downtown with a very dear lady whose name is Mary, and she has a thrift store on Main. It was during the pandemic and I wanted to check in on Mary, and I went in and a gentleman came in from the street, and I was taken a little bit aback because she doesn't get a lot of walk-ins, especially during the pandemic, individuals coming into the store, and he looked a little bit rough. Mary is an older lady, very vulnerable, and he was a little bit gruff. And when I stepped back, my nonverbal to him was that I was afraid. And he said to me, "You don't need to be afraid of me. I'm not going to hurt you. I'm just coming in to shop." And that was a slap in the face. Our own biases, our own judgments, our own lack of self-awareness is a factor in our recruitment efforts, is a factor in our interactions with the members in our community. So what are we doing to raise awareness and work on our own biases so that we can be more culturally respectful and inclusive of the community in which we serve? Don't make cultural assumptions. If not making eye contact doesn't translate to disrespect in all cultures. It's actually the reverse. Tone of voice, maybe someone who comes across gruff in their tone, or maybe is aggressive to you, is not aggressive in their culture. Separate your questions to avoid confusion. Oftentimes when study team members are interacting with participants, they just go and go and go, and don't separate out the questions, don't ask, don't work through a situation and have dialogue. I tell people that if you are consenting someone or you're talking to someone about recruitment into a study, put down the paper, make eye contact, have a discussion, a dialogue, open communication, ask questions, wait for answers, slow down, and be in the moment with the participant or the potential participant and family that you're trying to recruit into your study. There are a lot of ways that we can be more culturally effective communicators and respectful, and helping to build that level of trust and respect with the research institution and our community members. And if you're uncomfortable, acknowledge it. If you hesitate because you're not sure how to say something, acknowledge it. Through the use of an interpreter, you can always pause and ask the interpreter for clarification if the participant or the community member has asked you something that you're unaware how to answer. That conversation, acknowledging that you don't know something, is a way to build trust, as opposed to faking it till you make it. I encourage you, if you are involved in research, know the research study in and out, the ins and outs of that study. Don't feel like you can just make it up as you go along. That dissolves the trust that we're so taxed with trying to rebuild. Give your time and attention when communicating. Listen actively and watch for body language. One of my interpreters told me that she had an interaction with a study team and a participant that was being consented, and the the participant had asked and actually begged the study coordinator to stop, that they were tired. It was a cancer patient, and they were being recruited into a study for their cancer, and it's a lot. Cancer informed consents, I have seen them as long as 46 pages. I will be honest with you, I review informed consents for HCI, and I can tell you when I review them, I myself will not sit and read 46 pages. So I can't imagine that someone who is going through such a difficult time would be able to sit there for 4 hours and go through an informed consent. Be respectful. Think about the need to meet your participants, your community members where they are. Sometimes it's just about slowing down and being in the moment and watching for those nonverbal cues from someone when you're talking to them. So who is in clinical trials? Oftentimes people are like, no, we don't really have a problem. This is, it's just a matter of they don't want to take part in our research study. I've heard that a few times. This is a study. There is a website hosted by the FDA. It's called FDA Drug Trials Snapshot. This is a great place. Unfortunately, when I went on there yesterday, I was trying to find a more current study. It looks like the site has not been updated since January 2021. And I actually emailed the FDA to question this, because I think if they are no longer going to keep this site up, that is a disservice to all of us that are involved in research and our community and patients. What this does is it shows who was involved in the research study, the drug, the demographics of those who took part. And again, when we know the health outcomes of individuals with some of these diseases, and we know who are most afflicted with some of them, and then we turn around and we look at the clinical trial and we see that in this particular case, 71% were white and only 21% were Black or African American patients. And we know that the impact of HIV and especially virologically suppressed individuals are not getting access to ART therapy. Therefore, they are not receiving the drugs, the therapy to help stave off a full-blown infection. And again, we can see it here in the results from the research study and the clinical trials and who took part. This right here shows why the need for diversity is an urgent emergency to be actively working with our communities, actively getting out there and recruiting individuals who would most benefit from the drug once the drug is available. And then again, on the flip side of that, making the drug available once it is FDA approved. There's such a lack of access. But if we aren't even including individuals who are most afflicted in the ability to take part in our research studies, it only perpetuates the healthcare inequities that we see. So this is another drug, a lupus drug that was approved also last year. Again, lack of diversity. Lupus nephritis actually impacts men more than women, although lupus itself has a stronger prevalence in women and African American women. But again, as you can see, the diversity in this research study was lacking. And again, not meeting the needs of the community that will benefit if this drug has been approved. But in the clinical trial, the individuals who make up a good portion of those affected by the disease are not able to take part in the research study. It impacts generalizability and reproducibility once a drug is either available or goes on to a second phase of a study. As we mentioned in the class standards, what is health literacy? According to the Patient Protection and Affordable Care Act of 2010, Title V definition says that health literacy is the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. So a high basic literacy, so I can read and write, doesn't necessarily correlate to a high or proficient level of health literacy. So what is health literacy? Well, from this, we know that's the ability to obtain, communicate, process, and understand, and make informed decisions. So when the National Assessment of Adult Literacy did their survey, they found that the average American reads between the 7th and 8th grade level. The average American is 20% of Americans read at the 5th grade level or below when it comes to health literacy. So 80% are above that. However, healthcare materials are most often written, we know this from research, at the 10th grade level or higher. So how do you think research materials rate? Research materials at best will rate at about a 10th grade reading level. They're complex, they're long. Most individuals, although may understand their conditions or the healthcare system, may not have ever experienced research. Most of us that are in research have never been asked to take part in research. So there is a huge disconnect between healthcare materials and research materials. There is a huge need to start talking about the importance of research, what research is, and why it matters. I would say at the K through 12 grade. So I have a video, there's a link to it later in my presentation. It's called Word on the Street, Health in the City on the Streets of New York City, 2008. It's a great little play on Sex in the City. A couple of interviewers went out on the streets of New York and asked individuals questions, basic questions about, to determine health literacy. The interviewer asked a gentleman who was in his mid-40s, can you describe to me what hypertension is? He hemmed and hawed. He said, hypertension would be an overactiveness of the muscles. And then he changed it and said, in the brain. And obviously, that's not what hypertension is. It's not overactiveness. That's not the only time I've heard that from an individual. The other question was, they asked a young man in his mid-20s, do you know what a stethoscope does? And he said, no, is that the same thing as a microscope? And a stethoscope is something, if you've gone to the doctor, you see it every single time when they listen to your heart. So I encourage individuals, especially in the medical profession, anytime you're interacting with someone, it's better to keep things informative and to answer and ask questions with every interaction. Encourage you to watch that video. Here are some statistics from that survey that the NAAL did. And I put both of these up here because I thought it was very interesting. The last presentation I did, I asked individuals to weigh in on which one was easier for them to read. I was, in my own biases, is that the one on the right is easier to read. It was interesting for me to hear that other individuals thought the one on the left was easier to read. These are the numbers that are reflective of those individuals and the demographics that took part in this survey and their health literacy abilities. 41% were below basic, and the Hispanic population was 41% below basic proficiency in health literacy. And you can look through this and see, but I have another one. This one's a little easier to read. Same information. If we look at this, we can see that 36% are below basic or basic understanding of health literacy. So when we take that into consideration, when we're talking about research with someone, how does that impact recruitment and enrollment? Individuals are doing a disservice by not making sure that the information we're sharing is in an understandable and actionable terminology. So oftentimes people tell me that they can't dumb it down. And I said, well, it's not dumbing it down. It's making it clear and plain language so that everyone can make a decision about whether to take part in your research study and to have access to it. We can tell the world that we have all these great research studies going on and there's all this opportunity out there, but if we don't make it accessible to our community members, then it serves no one. So we have 12% of the population that is proficient, so able to make an informed decision on health related, based on to make health related decisions and care decisions. So if we have 12% that are, what does that mean for the rest of us? It means that we need to do a better job when we start talking to members of the community, our friends, our family members, when we start talking about healthcare and health opportunities and research, that we need to bring it to a level that's understandable for everyone and in a language that is their preferred language. I also did a recent Google search and wanted to know what the percentage of individuals that speak something other than English at home. And it's nearly 25% of the population that speak a language other than English at home. And that's the language that we need to be sharing our health information and our research opportunities in their preferred language, and the language that's most spoken by that family or that participant or community member. Proficient readers can interpret meaning and generalize. Below and basic take words literally. They read slower, one word at a time. A proficient reader will read with fluency, and they will persist in reading. So an individual that's given a 46-page consent form, 88% of us will not read that. 12% of us will. So what happens in the informed consent process? Are they understanding what they're being asked to take part in? Are they voluntarily signing up for something that they truly don't understand and just hope that you're giving them something that will actually be of no harm and possible benefit? So Healthy People 2030, the focus for Healthy People 2030 is to eliminate health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. This is the first time that Healthy People it's been Healthy People 2010, Healthy People 2020, Healthy People 2030. We're still talking about the same thing. This has been going on for decades about health disparities and health inequity. This time around, they've acknowledged that health literacy is a big piece of this. Health literacy is what determines health outcomes. If someone is below or at basic level of health literacy, their health outcomes are much less than someone who's proficient. So it's really important that we start looking at how we are either contributing to disparities and inequities, or we are honoring those where they are and giving them information that's understandable where they can make an informed decision. We have an obligation as an institution and as an organization that to provide information in a health literate way. There's personal health literacy, there's organizational health literacy, and organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So it is important that we apply this to the research that we're conducting. If we don't ask the right questions, we're going to get the wrong answer. It's going to skew the data, and we're going to have unreproducible studies. It's not going to be generalizable to the community in which it's meant to serve, and we just perpetuate healthcare disparities. This is something I'm very passionate about, is health literacy, access, and opportunity to research for all. Plain language supports all levels of health literacy. So when I've had individuals tell me, it's easy I can, of course, dumb it down for individuals who maybe struggle. Health literacy and plain language supports all of this. If I'm a proficient health literacy expert, doesn't mean that I'm not going to appreciate something being given to me in an understandable way that I can easily grasp and make decisions on. I can have a 46-page informed consent. I can either choose to read it or not read it. But if I sat and read it, I could probably make a pretty informed decision. I've been in research for 25 years. Most individuals aren't going to come in with that same level of understanding, nor are they going to ask the same questions. So if we can bring things to a level playing field and make it accessible for all, we are doing what I feel is a social justice-ish and bringing research to the community. The Plain Language Act of 2010 requires that federal agencies write clear government communication that the public can understand and use. Plain language, it's difficult to do, but it's much needed. So where do we go from here? I encourage you to reflect and acknowledge your own biases. And once you do, then we can work collaboratively together to be inclusive and change the scope of our research to be meeting our community members where they are. Apply class standards to all of our research, our study designs, our recruitment materials, and provide qualified language services. If we know that 25% of our population speaks a language other than English at home, we need to be ensuring that we are providing equitable access to all of the research that's being conducted at our institution and globally. Work on open communication. Have open-ended conversations and ask open-ended questions of your participants. when you are working on recruiting individuals into a study. Ask them if they, you have, asking open-ended questions is 10 times harder than asking yes and no questions and closed-end questions. I often have individuals tell me that they always ask their research participant if they have any questions. Would they even know the questions to ask? I like to compare it to when I go to the mechanic and my car is broken. I am not an auto mechanic and I don't understand most of what happens in my car to make it go. So when the technician tells me that something is broken, I typically just give them my credit card and have them fix it. I don't know and don't have the ability to understand it. And I think oftentimes individuals that are asked to take part in research also feel that way, overwhelmed, especially if it's a new diagnosis. They're very vulnerable. It's challenging. So when you ask an open-ended question, you can start to have that conversation. You can see where some of the information maybe that you have given has been misunderstood, and be able to correct that and have a discussion and build that level of trust and respect with our community members and our participants. Be the disruptors to the status quo. We no longer can sit by idly and let research continue the way it has for decades. We need to do a better job. And that starts by meeting our participants where they are, applying class standards, and acknowledging that diverse populations need to be able to access and be given the opportunity to take part in our research. So I'm going to close there. I would like to open it up and have everyone, if they're willing, to turn on their videos, ask questions. I'd like to have a discussion and answer any questions that you may have. There's lots of information here. I thank you so much for your attention to this presentation. Research equity is a social justice issue. We need to ensure that the individuals in our community have access and are given the opportunity. And with that, I conclude my presentation. You can contact me or the Office of Research Participant Advocacy, myself and the Language Access Services team here are their contact information and my information. I will stop sharing and open it up for discussion and questions. Does anyone have any questions?
Well, I just wanted to get us going by thanking you so much, for launching our education series with a wonderful presentation. Sorry I was a little bit late. I loved everything that you were talking about. It really resonated with me. And I'm sure the students and other folks joining might have questions. I think that one of the things when it comes to different audiences and who our research is for, and who we assume is going to be reading our research also impacts how they interpret when data is diverse. And so some of the things just to share, and I wanted to get your reflections on when, conducting research in Utah, and I recruit diverse participants and have been, and I work with community organizations and the data and the information we share with the legislature. And when they look at the diversity of participants, some folks might say, and have said that because it's not a white population and that it's so diverse that it actually is not meaningful, that it's being saturated by this diverse community. And so I wanted to know if you've run into that and how do you as a researcher, counter the folks who are countering the diversity of participants that we're recruiting?
I chuckle because I've had study teams and tell me that their sponsors come to Utah solely to recruit white, Caucasian, middle-class individuals. And I chuckle because it's like, no, we are a diverse population. We have 129 different languages. I would argue that it's probably even higher than 25% that speak a language other than English at home. The research needs to represent our community. I mean, that's one of, the requirements, right? The ICH guidelines is that research needs to be representative of the community and where it's being conducted. So every one of our studies, if we know the percentage of a population or a demographic, that population needs to if they're afflicted with this condition, needs to be represented in our clinical trials. And there's so many barriers put up that it begs the question, where are we missing? Where are we falling short? When individuals talk about diversity skewing data, I mean, how do you combat that? It's like the information needs to be generalizable across the population that are that it's meant to serve, right? So if it's a drug study, like the lupus drug, if 80% of the individuals that have that condition are African-American women, then 80% of the representation from that study should represent that. And I think pulling that data and sharing that with individuals on a case-by-case basis, there's plenty of research out there that supports the need for diversity in research. It helps with generalizability and it helps with reproducibility. If nothing else, if you're gonna totally forget the social justice aspect, there's, hit them where the numbers are. The other thing I think that we need to think about is, we have to be the disruptors. We have to push this. We can no longer idly sit by and let it be done the way it is. I had a researcher tell me one time, he's one of my bigger utilizers now of our research translation interpretation office services, but told me that non-English speaking women didn't make good participants in his OBGYN studies. I said, what are you doing wrong? There's obviously, if you're not able to recruit a diverse population, you need to do some self-reflection. You need to do some reflecting on the study design and the outcomes of that, what you're trying to accomplish. And oftentimes people will tell me that they can't translate their study into other languages because the tools have not been validated in that language. That begs the question, why? Work to validate those surveys and questionnaires in other languages, or change your survey materials. Thanks. Does anyone else have a question?
My comment is really, I guess, more of a comment. Maybe I'll talk myself into a question. But what I wanted to do was make sure that students who are watching the video or who are participating now who aren't doing clinical trials also get some kind of explicit discussion of how all of these concerns and issues and approaches also apply outside of the clinical context.
Absolutely.
Or yes. Research design, and which population are you working with? How are you reaching out? How are you making your materials available, regardless of the content of your study, right? If it's, I'm gonna make stuff up that doesn't make sense. So regardless of the content of your research study, thinking about how everything that Sadie said does apply in your context is super helpful. So Sadie, do you have thoughts on that?
Yes, absolutely. I think that's, I mean, I could do like 6 different presentations from this one presentation. It's not just clinical trials that this impacts. This impacts all research across every department, every group, every institution. I just met with Equality Utah, and they're looking at the need for some research regarding legalization of marriage for the LGBTQ population. And there's a potential concern that that would be the next target after the Roe versus Wade threat. And, everyone needs good, solid research when we go into these areas of concern or injustice. So it's not just clinical trials. It's not just about drug studies or therapeutic studies. It's about observational studies. It's about socio and economic studies, right? It's about social justice studies. All of these elements of the class standards, and I apologize if I didn't make that clear, this applies to all research. It applies to all of our life, right? It boils down to when they, in one of the class standards talks about bilingual and biracial staff, right? It's it's across all of this. It's not, it's about hiring practices. It's about policies. It's about, our small businesses. We need to realize this is not just a clinical trials element. This is research. And then this is also our community. So yeah, I encourage everyone to, if you see something, say something and question it. We are all in this. Unfortunately, I hate to say it, we're all in this together, as we've been saying for 2.5 years. But there are those of us that are in a privileged position and have the ability to fight this fight alongside our marginalized communities, our underserved and underrepresented community members, and our friends and our families and our colleagues and peers. It's across the board. So.
So we have a comment in the chat, and I'll just read it out so folks in the video get all of the information. I really like this presentation. I thank you for showing so many of the problems that people who speak another language or that we're a minority present. I agree 100% with everything that you mentioned. I've lived it, and now that I'm in a different position, I'm motivated to make sure that all people have access to information. Thank you.
And it's a right. So as a researcher, as a community member, you have the right to a qualified interpreter. If the patient, the participant, the colleague doesn't want an interpreter, you still have a right if you don't speak the language. That's how we build trust and respect. Thank you. Thank you for that comment. Anyone else? Well, thank you. If you have any questions, please don't hesitate to reach out to myself or my team. We are here to serve every one of you, undergraduate researchers, students, faculty, staff. This is, obviously our office is very heavily committed to representing our community and participants at large and potential participants. So thank you.
I'm going to share my screen with my outro slide, just so we can close on something similar to the first slide, and remind everyone who has logged in real time, your attendance has already been taken care of. You don't have to fill out that evaluation sheet that's linked in the chat, but if you want to, that would be great. That's always very helpful to us. And for those of you watching the video later, please do fill out the education series evaluation form with your unit, so that I can make sure that I track your attendance and give you all of the appropriate credit for having done that. And I just want to say thank you so much, Sadie. Again, like Dr. Fukushima said, for starting off the education series. And like we had started the day saying, and presenting on a difficult day. I appreciate the effort that you've put in here.
Thank you. I appreciate the opportunity to serve you.